The Rare Kidney Source podcast is for informational and educational purposes only and should not be used as medical advice. Please speak with your healthcare provider before making any treatment decisions. Before we get started, don't forget to subscribe and hit the notification bell so you never miss an episode. Follow Rare Kidney Source on YouTube, Instagram, and Facebook, and listen or subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts.
It's easy to completely believe the lab result. There are certainly a lot of pitfalls with lab testing. So just because a number is generated, it doesn't always mean that that's entirely accurate, right? Because there could be problems with either the blood draw, the urine collection. And so sometimes just looking at one data point could be a little misleading. And so that's why I think a lot of times the clinicians will repeat the labs.
Well, I have to say they've never actually been explained to me. I find it's better to go to the internet. AI is a fabulous tool for that. And I can ask the internet what these tests are for, why I'm taking them, what they mean. And it explains it much easier even than a doctor would, especially with C3.
That's kind of terrifying.
It's like being handed a dashboard full of warning lights and no manual.
And no mechanic to explain what the manual means. Have you ever looked in your car's manual? It's nonsense in there.
Yeah, like what is an emergency brake anyway?
For a lot of people living with C3G, that's exactly what it feels like. All warning lights, no manuals.
On the last episode, we talked about your body having an alarm system with signals going off when something goes wrong.
But an alarm can only tell you that something's wrong, not what's wrong, and not how serious it may be.
And that's where your labs come in. And labs aren't just sounding the alarm.
They're showing you what's happening under the hood and whether things are getting better or worse. You just need a proper manual to figure it out.
Oh, that's what an emergency brake is? I guess manuals are important. No wonder my car rolled down that hill last year.
Welcome to Rare Kidney Source.
This episode of the Rare Kidney Source podcast is sponsored by Apellis Pharmaceuticals, where courageous science and compassion drive our commitment to the rare kidney community. We believe people living with C3G and primary IC-MPGN deserve connection, understanding, and a community built around their needs. That's why we created Rare Kidney Source, a destination and podcast featuring real patient voices, leading experts, and trusted conversations to help you navigate your health journey with confidence. We're here to help you stay informed and connected. Visit rarekidneyandyou.com today.
Today, we're breaking down your labs and what they actually mean.
What they don't.
And how to make sense of them in real life.
Hi, I'm Anthony Chang. I'm a renal pathologist at the University of Chicago Medical Center. I've been here for almost 22 years as a practicing pathologist.
Hi, I'm Anna. I'm a C3 patient, and I live in Vermont with my family.
On one side, you've got someone who studies kidneys under a microscope.
And on the other, someone living with C3G every day, trying to make sense of the numbers.
One of the first things that they'll probably be tested for is to check on their serum creatinine. And that's a useful marker, although it tends to be not very sensitive. So even if that number might be in the normal range, there's a possibility that the patient could already have chronic kidney disease, depending on whether, they might not have a whole lot of muscle mass. And so then their creatinine could still be in the normal reference range when perhaps it's higher than it should be for their body size. Other things, including urinalysis, nephrologists are always checking for the presence of protein or blood in the urine. Those definitely should not be there in a normal functioning kidney. So the presence of those are indicative of an abnormality, and typically that might involve the glomeruli. For our topic today, typically the nephrologist also assesses for complement C3 and complement C4 levels. And so if those are decreased, that might also provide additional clues in terms of what may be the underlying disease.
Okay, pause. Let's break that down.
Because that is a lot of information. We just heard a lot of words that could win Scrabble by a landslide. If only we knew what they meant. Kay, a little help here? It's making my brain itch.
Let's take a quick step back. When we're talking about C3G, we're talking about a kidney disease where part of the immune system, called the complement system, goes into overdrive and can damage the kidney's tiny filters.
So a lot of these labs, they're trying to figure out how those two things are behaving.
Think of your labs like a dashboard. Creatinine is kind of like your fuel gauge,
Okay, gearhead.
but it doesn't always drop right away when something starts going wrong.
Protein or blood in your urine?
Those are your warning lights. That should not be on. But in these rare kidney diseases, they tend to be one of the first signals that something isn't right.
And C3 levels,
That's a peek under the hood, taking a look at all levels that's caused by an overactivated complement system that's driving the disease.
and here's the part that messes with people.
Everything can look and feel normal and still not be okay.
I would get very excited about a certain number, and my husband would say, well, that doesn't mean anything. What's the trend? And I never thought to look at the trend. And I said, well, it's in normal ranges. And he said, yeah, but look at where the trend is going. It's going up, and you don't want that. And why is it going up? So I think those are important things about labs that most of us lay people don't know.
That hits.
Because we're all looking for that one number that tells us we're fine.
Like, just give me the green light and I'll move on.
But this isn't just about one reading on a dashboard.
It's how that reading is changing over time.
I take a lot of various tests, and I notice that the doctors don't. So if I'm going to one hospital and taking a test and speaking to a doctor there and then a different, which I do, they don't seem to look at the different tests. So they're kind of siloed. They're not looking at all of that. And then they're not looking at the trends.
I think one of the problems, and ideally, if the medical records were all connected, right? If you're at one medical center, their electronic medical health records are not connected potentially to another. So then the one doctor at one medical center can't easily see the old results from, the past. Ideally, it would be great if we were all connected, right? And I think that's sort of the dream, the hopes that one day that would be a reality.
So you're watching your dashboard, gathering different pieces of information.
But every update is coming from a different place, and none of it is really connected.
The other thing to also keep in mind is that sometimes you want to be careful about connecting these trends or looking at these trends, because the assays at one institution might just be a little bit different from the other. And so even the reference ranges can be slightly different. And so while generally they're fairly close for something like creatinine, there may be other assays where there's enough of a difference that it will be harder to compare a test performed at one medical center compared with another medical center.
I do find that to be a big problem because they have different references, and I'm like, what does this mean? And that really is very frustrating for a patient, because I want to be on top of my disease. I want to know what everything is and be a partner in my care.
So C3 is a part of the complement cascade, and complement is a really important form of the innate immune system. And so there's sort of this constant balancing act that the body has to do, because if you have an infection, if you brush your teeth and you're introducing bacteria into your bloodstream, complement is there to get rid of that bacteria before it becomes a problem, right? Before those bacteria can divide and then cause harm in even a greater, extent. And so C3 is a really central part of the complement system. And so once you have these external triggers, the complement cascade gets activated and then amplified. And so then as the trigger goes away, for example, if your infection subsides or resolves, then eventually your complement system will also turn off. But it's not a perfect, system, right? So in some people where their regulation is not so tight, they're turning on this complement cascade allows that complement to be hanging around a little bit longer. And then that's potentially just enough to then cause issues. And that's kind of what underlies C3 glomerulopathy.
Like we mentioned earlier, we introduced the comparison in the last episode that your immune system acts like security.
But if it doesn't stand down,
It starts damaging your own building. You are the building. We like metaphors here.
that is what's happening here.
A steady number sometimes could be a little bit deceiving because you can still have loss of nephrons and your creatinine might remain the same. And that's why we're looking also for protein in the urine or proteinuria, and then blood in the urine or hematuria. A normal kidney should not allow any protein or blood in the urine.
Wait, so things can be getting worse.
Yeah, and it's important because with conditions like this, you can feel completely fine while damage is still happening under the surface. Just because nothing looks off day to day doesn't mean the disease has stopped progressing.
And that's why signals and labs matter, even when you're not feeling symptoms, because the absence of warning lights doesn't always mean everything is okay.
I mean, ultimately, you do need the kidney biopsy to diagnose C3 glomerulopathy or C3 glomerulonephritis. And once you have that diagnosis, then you can use the creatinine to try to keep track of whether the renal function is stable or not, although we talked about how that's not completely sensitive. And if you have someone who already has been diagnosed with C3 glomerulopathy, then the presence of blood or protein may be really important in terms of telling the nephrologist, is there ongoing injury that is potentially occurring within the kidneys?
So if your labs are the dashboard, the biopsy is where you stop hypothesizing and start seeing what's really going on.
When you crack open that manual and realize you haven't been properly engaging your emergency brakes.
Hey, that one felt targeted.
So as a pathologist, I'm typically only involved when they perform a kidney biopsy, and that really is dependent on, the nephrologist typically decides that they want kidney biopsy to figure out exactly what is happening in their patients. And so by the time that occurs, then those specimens are sent to our pathology lab, and then we will evaluate the tissue. The tissue is processed. We'll be able to look at the tissue on glass slides under our microscope. And then we have several other types of microscopes like the immunofluorescence microscope and the electron microscope. Right now, repeat kidney biopsies or subsequent kidney biopsies isn't very usual in diseases like C3 glomerulopathy. And I think the repeat biopsies can be informative. I can provide an example where we had a pediatric patient where their initial biopsy that yielded the diagnosis of C3 glomerulopathy, there was no glomerular scarring, right? And then 3 years later, it seemed like he was still having protein in the urine and other symptoms and signs. So there was a concern that the therapies that they had were really controlling the disease. And so we did get another biopsy, and we saw that there was now 10% glomerular scarring. So how you could then, we talked about, looking at trends. And in this case, you have these two biopsies where the first biopsy had no glomerular scarring, and the second biopsy 3 years later had 10% glomerular scarring. You could almost infer that there's roughly a 3% nephron loss every year, and that got you to the 10% nephron loss 3 years down the road. And so then you can imagine in another 3 years, it would be 20%. And then another 3 years, it would be 30%. So we'll see. I think potentially maybe repeat biopsies will be informative in that way. But at the moment, it's not necessarily used in that manner because you still know what the disease is that you're trying to manage, And we have some of these non-invasive markers that can be used. And I think probably patients prefer not to undergo a kidney biopsy if they don't have to. So it's probably best to follow these assays and look at the urine carefully to see if you can get any clues that way.
So, can you actually feel what's happening?
Not really.
Well, that's not very helpful of the body.
It really isn't. That's why biopsy matters. It's the clearest way to see what's going on and to confirm diagnosis. And sometimes repeat biopsies are needed to understand progression, even when everything looks stable.
The downside is it's invasive, so it doesn't happen often.
So you can have all of this information, labs, even a biopsy.
And still not actually feel what's happening.
No, I honestly can't. I know some people can. I honestly can't. My husband will notice things if I'm more fatigued or my color is bad or whatever. The only thing I ever noticed was the foam in the urine. That was the only clue I had.
That's wild. Your body doesn't always tell you.
So your labs are speaking for you, even when you feel fine.
Like the check engine light coming on when your body seems to be running like normal.
And actually, I was very fortunate because my disease was discovered much by accident. They noticed a slight blood in my urine when I had gone for a totally different, unrelated test. And my GP was very concerned about it and kept sending me for things and finally said, listen, you should go see a nephrologist. So I did. And I had a wonderful nephrologist who sent me for several tests and said, something's brewing in your kidneys. I haven't got a clue what it is. I hate to do this, but I'm going to send you for a biopsy. I said, fine. And my proteinuria was not terrible. And it's well under control at this point. I'm one of the fortunate ones. So I don't really feel anything other than maybe fatigue.
So you can catch something early and still not feel it at all.
Yeah, and that is actually the scary part.
Why?
Because kidney damage doesn't easily heal or reverse.
The kidney is not a very regenerative organ, unlike the liver. So if you're lucky, you're born with 2 kidneys. And if you're lucky, each kidney has 1 million nephron when you're at full term. Right. And so you have those 1 million nephrons in each kidney, and that's all you get. Your kidneys aren't able to form new nephrons. And I mean, if you think about it, you can donate a kidney if you're healthy and you should be fine. Right. So that's essentially losing half of your nephrons. But for if you have someone with a kidney disease, that potentially may be knocking out these nephrons slowly, you clearly want to slow that down as much as possible. We now have a very good idea that proteinuria is a fairly good biomarker for allowing us to know that there is ongoing injury.
Wait, you don't get more?
Nope. No replacements, no backups.
So this isn't something you can just fix like a car part.
It's like losing pieces over time, pieces of a part that can't be rebuilt.
And so we now know that you want to drive that proteinuria as close to 0 as possible. That's the best thing that you can do for patients. And so that's the challenge is, can we do that?
Okay, so what exactly are we talking about?
Well, to start, proteinuria is a fancy way of saying protein is showing up in your urine.
That's not supposed to happen.
Normally, your kidneys act like a really precise filter, keeping important things like protein in your blood while letting waste and extra fluid pass through into your urine. But in these rare kidney diseases, that filtering system isn't working the way it should. So protein starts leaking through when it's supposed to stay in the bloodstream.
It's kind of like oil leaking out from where it should be sealed in, and that's a problem. Because it doesn't just mean something might go wrong. It can be a sign the damage is already happening.
So when we talk about decreasing proteinuria as low, what we really mean is trying to get things back into remission, where that leak is as close to stopping as possible, if not completely controlled.
Okay, I got it.
And how well can we do that? And I think, it's a very exciting time for nephrologists because they now have new therapeutic agents that they never had even 2 years ago or 3 years ago.
So that's the shift, being able to actually see what's going on.
Yeah, and what's really changed is we're not just sitting with the information anymore. We actually have better tools to act on it.
That's a pretty big upgrade.
It is.
So even with all of that,
You're still following things closely because it's not just about one moment in time. It's about tracking how things are changing over time.
right, and that's where things like lab days come in.
For me, hydrate, hydrate, hydrate. I think that's the key to not being dehydrated makes it much easier. And I'm a very difficult stick, so I make sure I'm well hydrated.
Okay, lab day checklist.
Step 1, hydration.
Step 2, bring someone who asks questions.
Because this isn't just about getting labs done, it's about understanding what they're telling you.
And then the other thing that I do is if my husband and I notice, he's very involved in my care, if we notice something that's not right, we may ask for an extra test.
That's the difference.
Yeah, between waiting and pushing for answers.
Actually, I have to say, my husband was the one that pushed. I would not have pushed so hard. If he was not with me at that appointment, I'd have gone home and my next appointment would have been 2 months later. And I would have gone home without the test. It gives you the ability to formulate the questions to ask your doctor.
And that's a big shift. You're not just reacting to the dashboard anymore. You're starting to understand what it's telling you. The manual's making more sense.
And once you understand it, you can actually do something about it.
Like engaging that emergency brake.
Maybe we just let that one go. I'm starting to feel embarrassed.
The tests are definitely very important, and having many to be able to compare and to have trends becomes really, really critical.
It's not about memorizing every lab.
It's about understanding what you're looking at and knowing what matters over time.
And part of that is being your own advocate. Like, hey, could you explain that part again? Without feeling weird about it.
But it's also about working with your doctor, so you're both looking at the same trends and figuring it out together.
It's really kind of a very limited snapshot in time when we're involved. And then most of the other aspects are handled by the nephrologists. So they're the ones that are ordering those lab tests, looking carefully at what's happening in the urine, and then going from there and then probably tweaking the, therapy as needed, depending on what those results are. But I often actually prefer not to know what a lot of the labs show. I like to just look at the kidney biopsy without really being biased by, any of the prior history. And then I like to obviously understand what's happening in the patient and whether the findings that we're seeing fit with the clinical story that's being provided. And it's always nice when it does fit. And sometimes we're able to have a sense of how long has this disease been there. Like I mentioned before, in the child who was diagnosed with C3 glomerulopathy, there was no glomerular scarring. So probably this was a very recent development regarding the onset of the C3 glomerulopathy versus in another patient, if they had, 30% scarring or 50% scarring, that usually indicates that the disease has been there for quite some time because typically the scarring takes months at least to occur. So if you have such a high percentage of scarred glomeruli, that's probably even going to be happening over years. And so we have a lot of clues that we can draw upon from the kidney biopsy in terms of maybe painting a more complete picture about what's happening in the patient. But yeah, I only really correlate with the labs after we have seen a lot of our pathologic evaluation is complete. Then we want to make sure that it fits with everything. So it really is dependent on a really good conversation with the clinicians, with the nephrologists, to make sure that we understand the entire picture. And then we understand either what drugs they've been on or those sorts of things that can really affect how we think about the kidney biopsy.
It's not just what's happening now.
It's everything that came before it.
C3 glomerulopathy we only recognized as an entity around 2010 or so. So in reality, it's only been recognized in the past 15 or 16 years. And now we actually have targeted therapy for this disease, 15, 16 years later. It's really phenomenal to think about it, because when I started my fellowship training in 2004, C3 glomerulopathy did not exist as a recognized entity among my peers, right? Certainly this disease was there, right? It's been there forever, but our medical community didn't know that it was a thing. We were kind of left with C3 glomerulopathy. And so it allowed us to be able to see it more clearly instead of having all this other stuff that was kind of clouding the picture. So it's really kind of a phenomenal story regarding sort of how this disease has evolved, and then also how potentially we have targeted therapies to slow down the progression of this disease.
That's actually a huge shift.
Yeah, this isn't just about identifying the problem anymore.
We're finally getting to a place where we can respond to it.
I believe a patient should be informed and be part of their own care. And AI is a great tool. It's not a be-all and end-all tool, but what I think patients should realize is it gives you the ability to formulate the questions to ask your doctor. That helps everyone. And so many patients I know, especially being in this community, it's a difficult disease to have diagnosed. Many nephrologists aren't aware of it. And so many patients don't find out until it's too late, which is what I have learned from many, many people. And the ones who are very informed usually figure it out almost before the nephrologist does.
Your labs aren't just numbers.
They're signals.
They might start as an alarm.
But over time, you learn how to read the dashboard.
And when you can read it, you don't have to wait for things to get worse.
You can act sooner, you can ask better questions, and you can be a part of what's going to happen next.
This is the Rare Kidney Source.
And we're just getting started.
To learn more, resources and tools for patients are available at rarekidneyandyou.com. The Rare Kidney Source podcast is produced by Bloodstream Media and made possible by Apellis Pharmaceuticals. If this conversation resonated with you, make sure you're subscribed and tap the notification bell so you don't miss what's coming next. Follow Rare Kidney Source on YouTube, Instagram, and Facebook, and listen or subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts. Thanks for being part of the community.